And we know the most common symptoms we come across in respiratory system are breathlessness and cough. There are many other symptoms as well. Today we will be discussing in detail this breathlessness and cough. First, breathlessness. And regarding the prevalence of breathlessness, we know in palliative care, we see both non-cancer as well as cancer patients. And coming to this symptom breathlessness, it is most common in COPD and lung cancers, cardiac disease, heart failure, renal disease, advanced cancer with metastasis to lungs and all. Next. Okay. How many of you have seen patients with breathlessness in your OP or IP units or in home care and all? Did you find it difficult to manage at any point of time? Yeah. What was the main difficulty that you have faced while addressing this breathlessness? Okay, the patient may be in a distressed state, right? When a person is feeling breathlessness, yeah, wheezing may be there. They may not be screaming, but uh, they may be anxious, right? Not comfortable. They may not be in a comfortable position. They cannot even speak or communicate their problem because of this breathlessness. And it is one of the most common distressing symptom like pain. So when a patient is having severe breathlessness and when the underlying condition is being present for a long time, they may have experienced this breathlessness previously also, and when it is severe, they may have a fear of dying, or they may think they may die soon or like that way. So when they are coming to us, both patient as well as the family may be in a state of complete distress. And because of all these reasons, it will be difficult for us professionals also to manage the condition. I know all of you have come across this breathlessness uh, in your OPs or IPs or anywhere in your practice. Why? Because in bronchial asthma, COPD cases, which is very common, not only in palliative care, in other cases also, we used to see this breathlessness. But uh, in early stages, it is easy to manage, and the underlying pathology is difficult to is easy to tackle in initial stages. But when it is progressive, when we are dealing with cancer cases, and when it is in advanced stages, and other examples in COPD and in cardiac disease and all, when it is very chronic and in end stage or in later stages, the etiology may be progressive, and it will be very difficult to control the underlying etiology, and the symptom control is also very difficult at that point of time. So considering all this, it is a difficult symptom for us also, for professionals also to manage. Okay. And we should know how the patient describe breathlessness. And most commonly, the qualities of dyspnea is air hunger of unsatisfied inspiration, work or effort, tiredness. Coming to air hunger, the patient may describe it as I cannot get enough air, doctor, or my breaths don't satisfy me, or I am starving for air. What does that mean? Sometimes the patient may be sitting quietly, but when we are asking them, we may we may understand that they are starving for air. They are not feeling comfortable. Okay, so we should ask the patient itself. We should not assume that oh it is mild or moderate or severe breathlessness or like that way. So whatever, when a patient is coming to you, you should ask the patient itself how they are feeling. Okay. And work or effort. While you are listening to this class, or throughout the time we are taking the breath, right? But we are not putting any effort. We are not putting any effort to take our breath, right? So when it comes to a point that we have to put some effort to take even a breath, it is very distress for the patient. So patient may explain to you that it's an effort to breathe, or my breathing requires more work. So that itself points that the patient is struggling a lot. Okay, they may not be able to sleep peacefully, they may not be able to do their work, they cannot even concentrate on their day-to-day activities. They may have to compromise a lot of things. Okay, tightness. That means something heavy they may be feeling in their chest, or something is tying around their chest, like that way. That is most common in bronchoconstrictions. Next. Next. And main causes of breathlessness. There are many causes. Here we will see some of the causes. First, primary or metastatic cancer. We know lung cancers can cause breathlessness. Mostly, the breathlessness, severity of breathlessness may increase in their end of life or end stages. And metastatic cancer, any uh, breast cancer with lung mets, or CS stomach with lung mets, like that way. Any metastasis to lungs. Lymphatic infiltration by the tumor, and malignant pleural effusion. It can be malignant or non-malignant pleural effusion. Tracheobronchial obstruction. Any obstruction in the pathway. Okay. And the treatment, surgery, radiation, chemotherapy. Post surgery, the patient may feel breathlessness. Post radiation changes in the respiratory system can cause this breathlessness. Okay, next. Lung cancer, we have already discussed, and ascites. Uh, do anyone see the patient having breathlessness because of this ascites?
Hello.
Yes, ma'am. You can. Yeah.
Yes, ma'am. I have seen, ma'am, in the medical wards.
Why?
Ascites case, general ascites, not with related cancer, general ascites cases.
Yes. Okay. What did you do that time, sister?
At that time, that patients are very severe breathlessness with accumulation of the fluid. So
Yes.
we will advise the back rest, ma'am. At that time, we will
Okay.
mostly advise back rest. Doctors will advise the bronchodilators.
Okay. Okay. Okay.
Sometimes this nebulization also, ma'am.
Okay. Thank you, sister. Thank you, sister, for responding. And yes, as sister said, there may not be any lung pathology or any pathology related to the respiratory system. The breathlessness doesn't mean that uh, even though the system involved is respiratory, the main pathology may not be in the respiratory system. It can be in the heart because of heart disease, or because of any pathology in the lungs. It may not be ascites as such. It can be a mass. Sometimes the lung cancers, or stomach cancer, or pancreatic cancer, or many other cancers with multiple omental mets and all, or uterine fibroids, or uterine what cancer in uterus. In such cases, or ovarian cancer, in such cases also, there is abdominal distension. That is the main thing. Ascites, there is fluid accumulation. In other thing, the mass, which is causing an abdominal distension, and that distension will lift the diaphragm upwards. And we know the lungs is just above the diaphragm. So when we are taking the breath, inspiration and expiration, during inspiration, the lungs will touch on the diaphragm, right? So when it is being lifted up by the mass or fluid accumulation, which will cause breathlessness. And cachexia. Cachexia means uh, in cachexia, why that happens means there is respiratory muscle weakness and cancer microemboli in the lung, pleural effusion. Pleural effusion, it is the fluid accumulation, right? So in that case also, it may not be bilateral. Sometimes it can be bilateral. So all these cases can cause breathlessness. Next. Then coming to cardiac causes, cardiac failure, angina, arrhythmia, myocardial infarction, all these can cause breathlessness. And we might have seen patient coming to emergency department with symptoms of breathlessness. Maybe may not be complaining of any pain in the chest, but we should ask the history and we should rule out these symptoms. The breathlessness doesn't mean that something is related to the respiratory system. We should rule out the cardiac causes also when it comes to the acute management. But in palliative care, we should keep in mind, okay, all these can cause breathlessness. And pulmonary causes we already discussed. Among them are infection. Infections can cause aspiration pneumonia. All these things can cause breathlessness, pneumothorax, pulmonary embolism. Okay, COPD, these are most common causes. All of you might have come across all these cases. And psychological causes. And psychologically, it will cause an anxiety factor because of this breathlessness in the patient. Why? Because can you imagine a patient with breathlessness? Why it can be? Why can anyone respond? Okay.
Hello,
Yes,
hello,
ma'am.
ma'am.
Yes, ma'am.
Due to breath,
Ma'am, your voice is breaking. Okay. Next. Okay. The breathlessness is a common trigger for panic and it's a vicious cycle. That means when a patient is having breathlessness, they will have a fear of dying. I'm not telling about initial stages, okay? This happens eventually. Why? Because, for example, when a patient is been diagnosed with a COPD, maybe in their 45, 50 or 40s, 50s, they might have diagnosed with this COPD or cardiac illness or any other pathology. But as uh, as they come across after or many years, the condition will worsen and the amount of the severity of breathlessness will also increase. So in all these stages which is progressive, they will have a fear how it will be in the future, how if and when the severity increase, when they are having severe breathlessness, they may not they may tell you that doctor, I have imagined that I will die soon, like that way the patient may tell you. So that fear of dying itself will cause anxiety and it is a vicious cycle. This anxiety, when you are having anxiety, you will feel some sorts of dyspnea, right? I have felt that when I have no other pathology, even though when I am anxious I will have some sorts of feeling that I am feeling some breathlessness or suffocation or something on my chest, like that way. Did anyone feel like that? I think all are sleeping. Let us make this a session so interactive. So I'm not asking. Any other thing, it's just an experience. If you have experience, you can tell yes. Otherwise, no. It's okay. Yes. Yes. Yeah, this anxiety itself can cause breathlessness. Okay, so when it is being underlying, when it is being related to a pathology, that's a vicious cycle that acts as a vicious cycle, and the process goes on. So we should keep this in mind. When a patient is coming to your OP with breathlessness, they may be anxious. We have to deal with both of these things. We have to make the patient calm. Okay, and panic attacks may be there, or depression also may be there. These are the psychosocial aspects, and when we are dealing with palliative care, we know all these symptoms like pain, which is very difficult to manage, and we know the condition may not be completely curable. So the patient, it is very common. Depression and all, it is very common. Okay, next. And assessment. So, in order to address this any symptom, we have to take a detailed history and physical examination. And regarding the history, what we should ask when that began. Okay, onset we should know, right? When did it begin? What's the duration? How frequently does it occur? Uh, and regarding this, you might have taken the history in detail for pain, right? Pain assessment, what we are doing, when did that happen, and how it is progressing, and how frequently there is pain. Like that way, we have to ask for this breathlessness as well, and provocating as well as palliative factors. That means what makes it better and what makes it worse. Sometimes lying down on a supine position can make the symptom worse. In ascites and as in patient with abdominal mass or in pleural effusion and all, the patient may be feeling uh, suffocating or breathlessness while they are lying down in supine position. They may not be able to lie down peacefully, or in some cases, the patient may feel breathless on sideline position, on right side or left side, depending upon the pathology, right? And sometimes the patients may feel suffocating or breathlessness during the night time. After 2 hours of sleep, sometimes the patient may jump up feeling suffocated. Okay, all these things are important when they are feeling breathlessness. Is it throughout the daytime, or is it is associated with something, some work when they are walking? Some patients may feel breathless when they are walking on a when they are climbing stairs, or some of them have breathlessness even walking on level ground, and some patients may have breathlessness even on slight movements. Okay, we have seen patients in our ward having breathlessness. Uh, Even with position change, they may feel suffocated. So we should know when they are having breathlessness and what makes it worse and what makes it better, and these things. And quality, we have already seen how they are describing it. We should know this. And related symptoms, any cough or any anxiety. Sometimes there may not be any pathology. This anxiety itself can cause this breathlessness. Sometimes the patient may be restless, may not be sleeping well. So we should ask them what is the reason. Okay, and severity. You may know the pain score. Like that way, this breathlessness also we can score it from 0 to 10 for better what we will have a better idea about how severe the breathlessness is. In after treatment, also after initiating treatment, we can have a better idea how much the treatment helped them. And treatment, any treatment which is being taken for it the last days or last few years or something. Okay, the history should be proper, so that we will get an idea what is the cause for the breathlessness. Only then we can manage the breathlessness. Okay, next. And after history, we will yes, we will do the physical examination. Next. vitals, respiration. We should check the respiratory rate, whether it is, what's the normal respiratory rate?
16 to 20.
Yeah. So whether there is any increase in respiratory rate or depression, respiratory depression if it is there, or and the temperature. What's the significance of temperature? There may be some infection or something. So we should treat that infection, right? And the pulse rate we should see, and BP, everything. Vitals we should see. Next. Yeah, respiratory rate we will see that later. Next. Saturation and pulse oximeter. Uh, Coming to the saturation and pulse oximeter, we know it's the most common instrument that we use when a patient is coming to us with breathlessness, right? So even the patient will be asking us, doctor, what's the saturation? In our OP and IP, the patient used to ask us when they are coming with breathlessness and all, what's the saturation like that way? So yes, it's important to check the saturation. It is important to know the saturation and all. But in palliative care, when it is in advanced stage, the continuous monitoring of saturation is not necessary. There are many studies which shows that the continuous monitoring of saturation will not be helpful in any way to the patient and the family. It will add only anxiety factor to the patient as well as the family. Okay, next. Okay, and general physical examination, cyanosis. We all know it's a bluish tinge in the tongue and oral mucous membrane. Next. Okay, physical examination. In the inspection itself, we may know the patient is feeling the breathlessness. Without even describing the symptom, we may know when a patient is coming to us with severe breathlessness, right? So the patient may not be able to speak or communicate, and the patient may be taking a labored breath, or patient may be in a gasping stage, or if it is not like that, there may be nasal flaring. From inspection, we can see all these things, and there may be intercostal intrawing of intercostal muscles or subcostal muscles. All these things we can see from inspection itself, and respiratory rate also we can assess from what inspection. And physical signs, position of the patient. When we are seeing the patient in bedside, or when patient is coming in OP, we cannot make them lie down most of the case. Why? Because uh, on supine position, they may feel so breathless. So most of them prefer sitting position or propped up position. And active accessory muscles and nasal flaring, mouth breathing may be there. And in palpation, all these physical examinations are important. Okay, so we must have a basic idea how to do all these things. In palpation, what we used to do, palpation and percussion, especially in case of pleural effusion, pneumothorax, all these things, there will, and when there is a mass in the what uh, in the pathway or tracheobronchial obstruction of it is there, anything it is there, we can get it from palpation, percussion and all. Okay, so I think all of you have a general idea how to do all these things, and we should do palpation, percussion and auscultation. From these, we will get an idea that where the air entry is both equal on both side of the chest, whether the air is entering equally on all lung fields. You might have know all the lung fields and all. So whether the air is entering all lung fields equally, from palpation, percussion, auscultation, you should see this. Okay. If the doctor is unavailable, then you can also auscultate the patient and see whether there is any wheezing sound or whether there is any crepitations. What does that mean? There is a secretion. Okay, crepitations mean there is a secretion in the airway, and bronchi means there is a constriction in somewhere along the airway. Okay, and in pleural effusion and all, you will have very feeble breath sounds that will enter the lower lobes. So what you will feel is air entry is maybe reduced. And regarding means each one differs. Okay, so if you are doing the physical examination in all patients, you will get a more idea, and you will also feel something is different in this patient. Something underlying pathology is here. So you will also will get an idea. Okay, next. This is cachexia. There is respiratory muscle wasting, and when there is muscle wasting, the we know the inspiration is an active process. There is action of the diaphragm as well as accessory muscles. So when there is muscle wasting, the inspiration as well as expiration, the inspiration will be affected. So there will be breathlessness. Next, nasal flaring. We all have seen this nasal flaring. Uh, Mainly, even in small kids, we can see this nasal flaring. Yeah, next, management. In order to manage the case, we should know what we should know, why the patient is having breathlessness, what is making uh, this patient breathless. Okay, and what are the causes, or what are the things that makes the patient breathless? What are Is there anything that accelerate or stimulate breathlessness? Okay, anything like that? Or okay, so from history, from physical examination, we will have an idea. From history, Uh, from history, we will have an idea that whether they have taken any treatment for breathlessness. Okay, what are the medications they are currently ongoing, like that way. We will get a complete idea. Okay, so that should be there. And after having a better idea about the patient and the current status of the disease and current treatment plans and everything, we will start management. So we know management part is not only prescribing the medicine, first comes investigations, right? But is it necessary to send the patient for an investigation? Is it necessary all the time?
No,
Yeah. Why?
we know we can see the patient condition.
Yeah, already they may have reached you after multiple referrals and all, and after doing many investigations and making a diagnosis. Okay, so if you have no diagnosis in front of you, sometimes you may have to send them for some investigations. But when you are having adequate information regarding the diagnosis and treatment taken, everything, need not to send them for a investigation at all point of time. And in advanced cancers and in late stages in end of life and all, they are already suffering. So the line of management may not be changed by doing another investigation. So we should keep this in mind. We should not force the patient to do any investigation unnecessarily unless it is very important for starting a treatment. Okay, so for example, X-ray. If a patient is breathless, we may not need an X-ray all the time. We should do the clinical examination. We should go through the history properly, so we will have an idea. If the patient is having a severe lung, we know the pathology is there. So that is the reason for his breathlessness. Again, sending him for an X-ray, there is no point in sending him. There will not be any change in line of management again. And hemoglobin, why anemia can cause breathlessness? Yeah, we may think, oh, hemoglobin. We may not need to send the patient to a lab. We have lab facility. Sister will come and take the blood. But do you think it is also justifiable? Actually, no. Why? Because you should understand the suffering of the patient. We should not treat the symptom alone. We should treat the patient and the family. So here, the patient has undergone most of the patient when they are coming to palliative care, they might have gone through multiple treatments and blood tests and all. Okay, even a single prick for taking blood may cause pain for them. Even that, if we can avoid that, we should do that. Okay, if we already know the hemoglobin value for the last 1 month or something, okay, we need not to send them for an investigation, even if it is a blood test. But if it is necessary, then definitely we should do that. It is not like that the palliative patient doesn't need any investigation unless it is not going to change the line of management. We should not force them on it for sending them any for any investigation. And USD for differentiated pleural effusion from solid tumor. The solid tumor itself can cause pleural effusion on the same side. So, in order to know the present status of the solid mass as well as the pleural effusion, sometimes we may need to send the patient for an investigation. Yeah, but not necessary, not always. Okay, next. This is a case. So I request all of you to respond. Patient name X came to your OP with severe breathlessness. He is having advanced disease and not treatment possible, and who is accompanied by his family who is very anxious about his condition. What will you do and what happens in a regular setting? Suppose, I think most of you are working in palliative care, so you might have a better idea. So even though all of you can respond, how it will be, what will you do in a regular setting? Yeah.
Backrest given.
Okay.
Symptomatic treatment, madam, bronchodilators and crucimates, ma'am. Diuretics. Diuretics also we will advise. Bronchodilators also we will advise.
Check the vital and
Then
the furosemide.
Okay. Okay, check the vitals. Yes. Suppose the saturation is 80 or 75. What will you do?
Oxygen given.
oxygen is 10 liters, 10 to 12 liters we will give, ma'am.
Okay. It is an advanced disease, and we have given oxygen for 15 minutes. Oxygen saturation has improved from 75 to 78, but it is still below 80. So, what will you do?
Oxygen started, no?
Yeah, oxygen already started.
Then we'll advise, ma'am, any medications, ma'am, like that IV bronchodilators also will decrease the breathlessness. Then diuretics also will reduce the breathlessness. Then we will give the parenteral route, ma'am, other than the oxygen.
Okay. Yes. Thank you, Sister Ji. Yeah. Any other response? Okay. How many of you are expecting a better relief for this patient with bronchodilators, diuretics, and oxygen? A patient with advanced disease, no treatment possible, who is
Then
in.
Paula's position is there, ma'am. One more position, Paula's position.
Yeah.
That is also will some little bit reduce the breathlessness.
Okay. So,
Some inhalers.
okay, yes, these are the things. Yes, thank you, sisters. Thank you, everyone who has responded. Yeah, these are the things we usually practice, right? When a patient is coming to us with severe breathlessness, we used to check the vitals. We used to connect them to a if ICU setup is there, we may shift the patient to an ICU, right? Is it yes? Next. If there is an ICU setup, usually I have seen in hospitals, when a patient with advanced cancer or advanced disease is brought up with severe breathlessness, they will definitely take the patient to a ICU or shift the patient to ICU. And they will be putting upon continuous monitoring of vitals, and they will start administering this oxygen mask and oxygen, and yes, IV bronchodilators, inhalers, everything, nebulization, everything will be given. And if it is the patient is not responding, then some BiPAP even can be started, can be maybe started. Okay, these are the things we used to see in the regular setting, but it is not the case in palliative care. Okay, when a patient is being coming to us, if we are doing the same practice as in a regular setting, there is no point, right? So we have to think differently and we have to treat them differently. Why? Why? Because we are not expecting uh, what is the ultimate aim of palliative care? I think we have to treat the patient. We are not treating the disease alone. We are not treating the symptom alone. We are treating the patient as a whole. So we should consider their suffering. They are coming to us with advanced cancer with no treatment which is possible. In that stage, only comfort care may be possible for the patient. So we should know this first and we should communicate that to the family. Initially, it may be difficult for the family members to accept the situation. So, what we should do is, yes, for acute management, we can check the vitals. Definitely, we can check the vitals, and we will have a better idea what's the current status of the patient. If the saturation is falling or something like that, definitely we can give oxygen. I'm not telling oxygen is not necessary. Oxygen can be given. We will see that in detail how the oxygen should be given in a patient with breathlessness. And we should address the patient as well as the caregiver. And we should explain about his condition, his present condition. We should communicate and the benefits of the treatment as well as life expectancy of the patient. We should know and we should communicate to the patient. Okay, and regarding the management, we will see that in
Okay.
detail.
Accelerate.
Next. Yeah, shifting. I have already told. We should ask the patient as well as the family what they are expecting from us. Okay. So sometimes when they are coming to palliative care, they may not know what is palliative care. We should explain them what is palliative care, and sometimes the family members may be unaware. Okay, they may have demanded use for ICU setup or ICU admissions or some continuous monitoring or like that way. But as a medical professional, we should do what is good for the patient. We should advocate for the patient. Okay, we only know what is good and what will benefit them and all. So we should have a better idea at this point of time what will make them better, what will be helpful for the patient, what treatment can make them comfortable and or whether these treatments will add more burden to the patient or more distress to the patient. Okay, so we should have an idea and then we should communicate to the patient as well as the caregiver. Sometimes it may be not be possible to communicate to the patient. We should communicate to the family, and it is not the health professionals who is taking the decision. We should make the patient and the family to decide on further management or further line of management. Okay, next. And we should do as every symptom we should do the correctables, and for every symptom there is non-pharmacological as well as pharmacological management. Next, correctables. If there is any infections and all, we can start antibacterials. And COPD asthma cases, as you all have said, bronchodilators and corticosteroids can be used. Pleural effusion, then thoracentesis can be done. That will give some relief for the patient for some point of time. Sometimes the catheter, pleural catheter can be placed if it is severe, and ascites, paracentesis, diuretics can be started, and divarasynthesis can be done, anemia, blood transfusion can be done, heart failure, diuretics, and AC inhibitors can be used. And in all these cases, for example, yeah, in COPD and all these cases, the breathlessness may be chronic, but at the end of their stage, the severity of breathlessness will increase, as I have already told you. And this anemia and all, yes, that can also cause breathlessness. Blood transfusion will help. Heart failure, yes, at some point of time, it will help. All these medications will help the patient. Next. Non-pharmacological management. We should calm the patient as well as we should make them calm. We know already the patient is and the family may be very anxious. We should tell them the reason and what can be done for the patient, and loosening the patient's clothes if it is tight, and using a table fan. The studies have shown that the cool air, when we are providing or supporting them with a fan, that will help in air circulation and they feel less breathless. These are supportive factors. Okay, this alone cannot manage breathlessness, but these are supportive things. And keep the room windows open, increasing perception of space and comfortable position. Yes, propped up or semi-flawless position that we can suggest them, or we should make them should not make them lie down on supine position if they are feeling breathless. We may have seen patients bed having piled up with pillows and all. So we can suggest them backrest as you have said, and modified breathing technique. The heart rate may be very, the pulse rate and all may be very high. So the meditation or diaphragmatic breathing, this is not in case of severe breathlessness, but some uh, modified breathing techniques can also we can advise. Next. And coming to pharmacological management, bronchodilators, we know there are short-acting as well as long-acting bronchodilators, and along with oxygen supplementation, corticosteroids. In case of lung cancers or in malignancy, what that do is that will decrease the peritumoral edema, not only in airway, overall, where there is a mass, it will reduce the edema, and that will help with the breathlessness. How means there may be a mass in the tracheobronchial tree. So when the edema is reducing, there will be more space for the air passage. So it can help. And the alveolar space will increase. Even a little increase in this airway space will help with breathlessness. Along with the corticosteroids, if we are administering this bronchodilators, it will be more useful. And yeah, next. And up to this line of management means still using bronchodilators, oxygen, everything, steroids, everything you already know, right? Then what is the point in taking this class for all of you in palliative care, especially in palliative care? Why? Because all these diseases that we have seen till now may have an intractable dyspnea. In COPD, are you expecting any complete cure? No. In lung cancers, cardiac failure, all these cases, I just mentioned a few, but all the cases are chronic, and in cancers, it may not be chronic, but it is not going to be completely cured. The pathology is going to be progressive, and the dyspnea is going to be not responding to any treatment which we have already seen till now. Okay, we are not expecting because the patient may not be coming to you in the initial stages. They may be they may be coming after multiple physician visits, respiratory medicine. They may have started medicines from respiratory medicine. All these things, oxygen, bronchodilators, everything might have been tried by the patient, and after that only they may have reached you. Okay, then again, if you are prescribing and again, if you are suggesting the same, there is no point in referring to a palliative care setup. Okay, so we should know this. First, we should know this as palliative care professionals. We should know this. So, morphine. Morphine is a wonder drug. It's an opioid, we all know. And how many of you have seen cases where responding to morphine for breathlessness? How many of you have seen? Or how many means in your setting, whether you have more? I don't know whether you all of you have morphine in your settings, but uh, how many of you knew this before that morphine can be used for breathlessness? Do anyone aware about this before? Yeah, when I have asked you about the treatment, you have many of them have responded. I know those who have not responded also know this very well. The bronchodilators, oxygen, all these things will help. Definitely, it will help. But at end stages or in some cases, the like this, uh, they may not respond with bronchodilators, oxygen, and all steroids alone. So we have been using this morphine for breathlessness in our setting, and there are many other studies also, and we have seen patient responding to breathlessness with morphine. So you should keep this in mind from this point of time, that if a patient is coming to you with intractable dyspnea, that means a dyspnea which is not responding to any other treatment, you can start them on morphine. Okay, yes, it's most commonly used for pain, but uh, another use of morphine is for breathlessness. What does this morphine do? It slows down the respiratory rate, and it reduces the excessive respiratory drive, and it will reduce the sensation of breathlessness. So it is very effective, but we need not to start the morphine uh, in a high dose. We used to start the morphine in a very low dose. That means 2.5 milligram, 6th hourly you can start, or 8th hourly you can start and see the response in 2 days. Okay. So need not to hesitate to start the morphine in intractable dyspnea. Please keep this in mind. The main reason for taking this class for you is to familiarize that morphine is one of the wonder drug for not only for pain, it creates wonder in breathlessness also. So if anyone is asking you in future or any patient is coming to you, you can if the morphine is not available in your setting, if you are feeling that the patient is breathless, if you are seeing that patient is having advanced disease, you can refer the patient to a setting having morphine. Okay, so it will definitely help the patient. Okay, only if you see the response you will be more confident enough to start. But there are many studies, and I myself have seen many patients getting very good relief after starting this morphine. Okay, 2.5 milligram, with 2.5 milligram you can start, and after assessing and after following up, then you can increase the dose. And when we are giving this morphine, we should explain them why we have given this morphine. Yeah, it is not only for pain, it is for breathlessness. You should explain the caregiver, otherwise they may not give the medicine. They may think that it is for pain, doctor have given this. You should explain them, it is not for pain, it is for breathlessness. For breathlessness also it can be used, like that way you have to explain them. Next. And toxicity signs and all you should explain, and you should follow up also this patient who has been started on morphine. And benzodiazepines, we have seen that the patient will have anxiety. Yes, it is necessary to relieve the anxiety. For that we should start some anxiolytics. Do you know lorazepam, midazolam? Lorazepam is long acting, short acting it is midazolam. The addressing breathlessness itself will reduce some source of anxiety. Then we should communicate, we should sit with the patient, we should reassure them that we are with the patient, so that all these things can reduce the anxiety, as well as okay, we should follow up also. Not, we need not to start this in all point of time. If it is not controlled only, we will start the anxiolytics. And then oxygen trial. Yes. Feeling breathless means oxygen deficiency. It is not like that, but in some cases it will help. It is helpful. Coming to palliative care, when a patient is coming to you with advanced cancer or advanced COPD, heart failure, pleural effusion, in such cases, we should understand that many studies have suggested that this oxygen has just a placebo effect only. Okay, the giving this oxygen, we are not restricting or we are not suggesting that, advising that not to give oxygen. We should give oxygen trial for 10 to 15 minutes or some. Okay, and we should check whether the patient is feeling comfortable, whether the patient's saturation is improving or not. If it is not improving, okay, in end stages, the cells may not be taking this or taking up this oxygen. Even if you are administering this oxygen, the oxygen level may be falling down. So there is no point in adding more distress and make them more uncomfortable with the nasal face mask and cannula and everything. So you should keep this in mind. When we are putting a face mask on a patient, they cannot even communicate very well. They may be having a very feeble voice and also, and it is a barrier for the communication, and the space between the family and the patient is also compromised. So, and they, if the patient is conscious, most of them denies the oxygen mask and all. So we should keep this in mind that we can give an oxygen trial in late stages, in end of life and all, when a patient is coming, and let's see whether it is responding, whether the patient is responding with this oxygen. If it is responding, you may continue. If it is not responding, then we should communicate to the family regarding why it is not responding, what is needed for the patient, whether it is adding more distress to the patient. It is not what it will not make them having a comfortable make them comfortable with this oxygen face mask and all. So you should communicate that to the family. You may have to sit up, and then we may need to remove this oxygen trial, or we may have to stop it. Okay. And oxygen saturation continuous monitoring also not necessary. Why? Because when we are placing a pulse oximeter on a patient, they will be looking into that multiple times. The family may be looking into it multiple times. Oh, what's the saturation? What's the saturation? Okay, in an end of life, in an at the end of life or in late stages, what we are expecting by palliative care to that patient is making a better time for them. Okay, by addressing the symptom, uh, and if the patient is symptom free, we should make them more happy. We should make them spend time with the family, or what is their wish, and like that way we have to address many things. So even if 1 day or 2 day which is being left is important for them, so we should not what we should not destroy that with putting this face mask and adding things or administering things which is not helpful for the patient and the family. Next. And next symptom is cough. Yeah, in cancer, CA lung, as well as in COPD, it's very common. And it's also the patient's subjective experience. And they may feel isolated by because there may be foul smelling discharge and all. The patient and means family members may be, or society may be afraid whether it will communicate, means communicable disease, whether if it is like that or so. What happens is they may be isolated to a room or something like that. So this also cause psychosocial or psychological impacts on patient. Next. And causes of cough in palliative care. Yes, tumors. Tumors, yeah, we know airway is some obstruction in the airway. When there is an obstruction, then there is air entry that can irritate, and that can cause cough. And cancer involvement of pleura, pericardium, mediastinum, pulmonary lymphatics, blood vessels, all these can cause cough due to irritant. Then aspiration, we know when a patient is taking food orally, and when there is a if it is not being swallowed fully, it can cause aspiration, and that means sign is the cough, the presence of cough. Aspiration, pneumonitis, pneumonia, all these can cause this. Next. Yeah, hypersecretion of mucus. The ciliary clearing, if it is affected, that can also cause cough. Next. What are the complications? The physical complications include there may be chest wall pain, there may be fracture of ribs, there may be urinary incontinence, there may be sweating, and so on. Okay, so we should keep in mind that second to this breathlessness, this cough can also cause can also affect the patient. So we should take the proper history and physical examination, which is same as before, and management of cough, treatment of means cancer related causes. If it is any infection or that, we should treat that. And steroids also reducing the tumor size, that will reduce the irritation and that will help with cough. And what radiotherapy, chemotherapy treatment, may palliative cough due to tumors. If there is any tumor, if any radiotherapy is possible, that will reduce the size of the tumor. Chemotherapy also will reduce the size of the tumor. If chemo, radio, and radiotherapy is not possible, the steroids will help. Along with chemo and radiation, also the steroids we used to give, that will also reduce the peritumoral edema. So the airway space will be there, irritation will be less, obstruction will be less. It will help with cough management. And yeah, we know we used to prescribe syrups having this combination of mucolytics, which may be centrally acting, antitussive, morphine in low doses, codeine, dextromethorphan. Here, uh, and what mucolytics like ambroxol, bromhexin, soothing substance like glycerol, all these can help with cough management. And we know this, but we may not be aware, like breathlessness, that morphine will also help in cough management. So you should keep that in mind. It may be for the first time you are hearing that for cough management we can give morphine, right? Okay, but for cough management also we can use morphine. Okay, it's a centrally acting antitussive. Why? Because dextromethorphan as well as the codeine, which is being already used in our daily setting. In most of the cough syrups, irritant cough or dry cough, if you see the combination, you can see this. But morphine is very rare. You may not find this morphine as a content in any of the cough syrup, but uh, it's an opioid which will help in cough management. It's a centrally acting. So I have seen and I myself have prescribed morphine for cough management, and for I have seen very good response in such patient. Very low dose may be needed. 2.5 milligram TDS 3 times may be necessary at the initial stage. And this breathlessness and this cough management, the dose of morphine usually we saw is it is less than 30 milligram per day. Okay, it is most commonly 99%, 90% of cases it is less than 30 milligram per day. But in pain management, you start with that dose itself. 5 milligram fourth hourly, which comes to 30 milligram. But in breathlessness and cough management, we need very less dose of morphine. We need not to start in a higher dose. That you should keep in mind. Morphine is useful, but need not to start in a high dose. In a very low dose, you should start. That you should keep in mind. And these are some of the symptoms. There are many other symptoms also, like hemoptysis, aspiration, and all. Hemoptysis, we know we have how we have to treat it, but the most common symptom we have discussed. Okay, thank you.
Dr. Greeshma, for the wonderful presentation. Anybody have any doubts? Please ask. If you want to share your experience also. Okay. Anybody?
Excuse me, ma'am. Here, madam used morphine only for the sedative and bronchitis, but there is no other opioids for the this bronchitis, ma'am. Only morphine is the drug of choice to this respiratory cases, ma'am. Other than the other opioids. What about, ma'am? Other opioids?
Other opioids means fentanyl and all. There are studies going on, and there is more studies that is being necessary. Most commonly, what we practice is prescribing this morphine or starting the morphine. But fentanyl and all have the same role, but the studies are still going on. Yeah.
Yes, ma'am.
Sister Sheba, is there anything to add?
Yeah, so what we need to understand is when we heard about morphine, we automatically
Little bit low.
What about now?
Now it's better, ma'am.
Okay.
Voice can't hear.
Okay. I think now my voice is clear, right?
Yes, ma'am.
Yes.
So what I want to tell you all is, especially nurses, among medical professionals also, when we heard about morphine, we at the same time we will think about the respiratory depression. So here we need to understand that the morphine is a big role for that giving breathlessness management. If the patient is having shortness of breath, you can use morphine. That is the best drug for controlling relieving breathing difficulty. So that you have to understand. So no need to afraid to use morphine for breathlessness patient. Okay. So anything any other questions? So there are many things because ma'am was discussed a lot. So what again I need to highlight with you all is here when a patient come with a breathlessness or one patient if a person's developed breathlessness, the family members will be panic and the patient will be panic. What extent that the patient and the family members will be anxious. So that anxiety we need to look into. So how we can do is that control the anxieties. You have to talk to the be with the patient and show them that okay, we are there to take care of you well. So no. So that that is one of the indirect message. And also you have to give a reassurance to the family members also. Always you have to here madam was discussed about the oxygen. Okay, so most of the time the oxygen is not good, not benefit to the patient. So just you just give a more oxygen trial and watch. After 10 minutes you have to, if you give an oxygen trial, after 10 minutes you have to remove the oxygen and ask the patient, is that oxygen is benefited or not? If the oxygen is oxygen support is benefited to the patient, then you can continue, otherwise you can remove it. So usually in end of life care oxygen is not that much benefited. So that is also keep it in mind. If you want to use that oxygen, better you can give through the nasal prongs. That again the mask will be again the barrier. They are not able to communicate if the patient is wearing mask. So better you can use oxygen prongs, nasal prongs. Thank you. Ma'am?
Yeah. Yes, sister, that's the thing. If we can avoid it, it will be better. Oxygen, we are not restricting any of you from giving this oxygen. We should give oxygen and we should see whether the patient is responding. The main point you have to keep in mind from this class is use of morphine as well as the oxygen use. The continuous monitoring of saturation may not be needed in all patients. And this oxygen, when we are stopping or when we are removing oxygen, you can just reduce it from if we are starting at 5 liter, when a patient is in severe breathlessness, you can reduce it to 4 liter, 2 liter, like that way. And you can see there may not be any change in response. Okay, even if you are giving it for 20, 30 minutes or 1 hour, there may not be any response. So just try giving this oxygen for 15 minutes to 20 minutes, then see if the patient is not responding, then gradually reduce it. By the time you should just communicate only after communicating to the patient, not patient, to the family members, after getting, uh, after making them comfortable, and you should explain them before removing this oxygen. Why you are going to do that? Okay, you should make them understand why we are doing this, why we are giving morphine, why we are not continuously monitoring the saturation. The communication along with the management you have to uh, do. Then only the patient and the family members will feel comfortable. Otherwise, they will get more anxious. Oh, patient is breathless. Still, this hospital sisters and doctors are not giving this. We can take the patient to another hospital. Like that way, they may decide. So, before doing anything, you should clearly communicate to the patient as well as the caregivers or family members. Sometimes we may not be able to make patient understand all these things, but gradually we should do. When we are addressing this in OP and all our IP, we may not be able to stop the oxygen in one day, but gradually we may need to do that. In home care setting also, some people, some patient may demand, some family members may demand oxygen throughout the day, but it may not be needed. In COPD cases and all, when they are doing some work or when they are walking around, sometimes they may feel breathless. That time you can administer oxygen. After that, you can remove it. Throughout the daytime, that it may not be needed for the patient. In long term, in chronic, not in advanced stages, uh, like that way.
Yes, as ma'am said, if there is an advanced stages there, you have to talk to the relatives and convince them first. Otherwise, they will take the patient to the another hospital, and the patient might be ventilated. So that is not going to benefit to the patient. It's again suffering. So in an advanced stage, you have to talk to the patient family and convince them.
And another thing is, first we should be aware about this. We should be convinced that this is not going to help the patient. Then only we can convince the family members. So that is the major thing that we intend to do in this lesson. Okay, we are not taking this class based on this just theory basis. Uh, our experience as well as many studies were undertaken before this. So from the studies, multiple studies are still going on, and this continuous oxygen, this saturation monitoring, all these are, they may increase the anxiety factor as well as the continuous oxygen and all have only a placebo effect in some many of the cases. That is the reason we are suggesting that we should not do that for patients. So I hope many of you got some idea regarding the management of breathlessness. And if morphine is not available in your setting, you should refer the patient to a setting which have morphine. So you should do whatever things which is possible, or you should try to get the morphine from that setting and give it to your patient. So because it is a wonder drug, it will help the patient a lot. Okay.
Yes, that is also very, very important. If you don't have this kind of money, that especially opioids, so please refer the patient to the another hospital which the morphine is available there, that the patient will get benefited. And our main aim is to make the patient comfortable as much as we can. So if the patient is having these kind of symptoms, is our primary duty to mitigate the suffering. So we have to keep it in mind all the time. So I think we can move on to the case presentation. Sister Manjula will be presenting a patient story today. Sister Manjula.
Angela ma'am, you are muted.
She is still muted.
My topic is respiratory system symptoms.
Yes.
Yes, ma'am.
Patient age is 70, female patient, diagnosed severe bronchial asthma, presenting complaints, depression, DVT, left leg pain, constipation, cardiac problem, hypertension, breathing difficulty, gastritis. History of illness, bronchial asthma since 10 years, cardiac issues when she is 25 years old, bradycardia, left patella fracture since 2 years. She can bend her knees only 60%. Her SpO2 is maintaining 92%. She is an old CA anal canal patient since 2 years. Examination, left knee pain, SpO2 92%, pulse 52 per minute, respiration 26 per minute, BP 130 to 130 by 70 mm of Hg. Treatment and significant investigation. Inhaler, home oxygen, LFT, RFT normal, Doppler normal. Psychosocial aspect, 70 years old female living with her husband and one son. Husband died 1.5 year ago, and son also died when he was 16 years old with cardiac problem. She is staying in her own house alone. She was a spiritual person who used to like reading books. Now she does not want to do anything. She is financially poor. Medication, tablet Reduxa 75 mg BD, tablet Abiva 100 mg 010, tablet clonotryl 0.25 mg 00 half, tablet pan 40 mg before food 100, tablet ecosprin 75 mg 001, IV plate 5 mg 101, Telma 20 mg 100, MDI Forocot 400 102, MDI Giova 020. Main concern, constipation, pain, sleep pattern change, financial issues, anxiety, depression, and loneliness. Summary, for knee bending problem, need to give physiotherapy. For depression, anxiety, and decreased sleep, given psychological support. Salt water gargle advised while using inhaler. Need to check saturation whenever she is not in oxygen. Pain and palliative care can be advised. Advised protein diet. Discussion point. What can we do to satisfy patient needs? How we can fulfill psychological and spiritual needs of the patient? How can we fulfill financial needs?
Thank you, Sister Manjula, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her, otherwise we can move on to the discussion points. So I think the case presentation is clear to everyone. We can move on to the discussion points. So we have learned many things today. Please tell us what are the way to satisfy the patient needs. So you have heard this patient story. How will you manage? We need to help Sister Manjula for helping this patient. So please put your comments. Please suggest something. We are expecting your response. We are waiting. Please switch on your videos. Manali, are you there? Lalita, are you there? Pennifer, are you there? Hardeep, are you there? Please switch on your video. Seema, Sangeet,
Yes, ma'am.
yeah. If they have any difficulty in switch on your their videos, please help them. Please switch on your videos. Manali, are you there? Ria, are you there? Rita, Mehak, Sunita, Preeti, Pooja Sharma.
Yes, Manali 7 is there.
Start video है ये तो वो दिखाई
Thank you.
Okay.
Okay, madam.
Yeah. What we can do to satisfy this patient needs? Before that, what's the main problem with her? There are 4 aspects, right? Physical. Is it physical aspects alone?
Psychological.
Yeah, psychologically she is affected. Economically also she is affected. Spiritually also she is very much affected. She was a spiritual person before, but now she is not reading any spiritual books. She has lost her husband as well as son, and she is also suffering. Right. So we may need to address the patient from all these 4 aspects. It is not easy. If it is physical alone, then we can even treat by giving the medicines, but it is not the case. So we have to address the patient from all these aspects. And physical, for breathlessness, she is on some bronchodilators. She is having bronchial asthma as well as the cardiac issue is there. So the patient is 70 years of age. So you can see the patient. If the patient is affecting a lot, then we can yes, if the patient is not responding to bronchodilators, steroids, inhalers and all, then definitely you can start morphine.
Ramani ma'am.
Okay, you can start morphine on this patient, but with this history, it is not means Sister Manjula has given a very wonderful case presentation. Still, we have to explore more how much she is getting relief from this bronchodilators, inhalers. Okay, when she is having breathlessness, and what makes her breathless. Like that way, the history you have to explore, and the relief for breathlessness with the current medication you have to assess, and then The steroids, the dose is 4 milligram. Yes, how long it has been used, and the inhalers nebulization also can be used. But if the patient is not responding, you should follow up the patient. You should not give the medicine for 1 month and send them. You can give the medicine for 1 week or 5 days and see how the patient is responding. And then, if the patient has no response with the bronchodilators, steroids, inhalers, nebulization, and all, definitely this patient is, uh, this patient can be started on morphine at very low dose initially. You should tell the patient why you are starting the patient on morphine. Okay. And next, uh, economic aspect, financial needs. You can, I don't know whether the patient have any other relatives or like that way. I don't know. Sister Manjula?
What about the family, others, relatives? You said she is staying alone. What about her siblings?
Ma'am, actually now she is having one caretaker is with her. And actually before she worked like a business woman. Now she is having little financial is there, support is there. But after that she is thinking about next what she will do like that.
Okay, she's already 70 years of age, so it may not be possible for her to do some work again and
Yeah.
make her earning for herself. She is a CA, non-case of CA. It is possible for her to get a CA pension or something, or old age pension. If she is not getting that, we should connect her to a social officer, or can help her to get some pension and all. I think it is available. It is there in our state. CA
That I have
pension and
the
all.
old age pension is there, madam.
CA pension and all. Is it there?
CA seniority is there, it seems, sir. But I have to check and I will tell.
Yeah. Or you can discuss that case with the social officer for any community involvement, or you can seek help from the community itself. What can be done for she's staying alone? She may not be able to cook her by herself, and at one point of time, sometimes we may have to think about shifting her to a proper care home at some point of time. If she can afford some caregiver and all, it is okay. But for some cases, if the patient is alone, if the patient is suffering, if the patient is not having adequate fund, if we are not able to mobilize the community support, then we may need to think about the care homes and all, but only after getting consent from the patient. uh, Sometimes the may want to continue in her own home. So maximum we should try to get community participation. We should connect them with the social officer. These are the things we can do. Any other suggestion from any one of you uh, that you have been doing in your setting, or you have seen somewhere? If anything is there, you can openly uh, discuss this here, so it will benefit the patient, and it will benefit all of all of us also.
Ma'am, Sister Manjula, you said that one caretaker is there. Is a paid basis or free?
Caretaker means her actually they are joint family, ma'am. Now her cousin sister maybe she is with her. Means
Okay.
no, she is taking care of her.
Oh, okay. Okay, fine.
Okay, that's a good thing. If any, I'm not discussing things based on this patient alone. Say all, I am just discussing. That means if a patient
Therapy
has
can
some,
be added.
have any financial need or something, we should, if the patient is an old age and all, they may not be able to do. So we should connect them to social officer. We should make them available we should connect them to available schemes. Uh, okay, and uh, family support we should mobilize, community support we should mobilize, and from our hospital or organization, if there is anything which can be given, that also can be done.
Thank you.
And how we can fulfill psychological and spiritual needs of the patient. Can anyone answer this?
Ragni, please go back to the previous slide.
Hello,
Yeah, yes,
ma'am.
ma'am. Yes.
Motivate to her to involve in the spiritual activities if near or there. If any spiritual members are will coming and going in that area, will motivate to her to involve that activities. One more thing, if any psychologist is there, then they need to take in psychological counseling also, ma'am. Hello.
Yes. Yeah, the spiritual aspects and psychological aspects is very difficult to manage in one visit. We may need to sit up with the patient and communicate, and we should ask them to vent. Means we should make them vent out their emotions. That's the first thing that you can do. And uh, when you are communicating or when you are sitting with the patient, she will open up what are her concerns, why she is not reading or why she is not spiritual. Okay. And for everything she is telling, you may not be having any answer. It is not necessary to give answer or find solution for every for all her concerns. But what we can do at this point of time is to listen to her, to actively listen to the patient, to make available for the patient our time. Okay. If we are doing, if Manjula sister is doing a home care, then you can spend some time, at least 1 hour or something, with her, so that she will vent out her emotions. And from that we can get an idea. From that we can get a better idea what can be done. For all her concerns, we may not have any solution, but there will be something at any point of time that we can do. So we should find out that we can take her to some nearby places. If she was going to a church, then there may not be anyone who is being taking her to church. So we can arrange some, or any holidays you can spend with her. Your team members can arrange a visit, can arrange a surprise visit for her, and can take her outside and make her happy, because there is nobody for her now, right? And we can ask her what was her hobbies before. Like that way we should, at first you should sit with the patient and you should listen to the patient. Then only you will know what are the concerns in her mind, what are the things. And multiple visits are needed, and communications should be continued. Along with that, the symptom management you have to do. Coming to psychological and spiritual aspects, these are the things you can do that cannot be addressed in one visit or 2 or 3 visits. You may have to continue your support throughout her life, and you should reassure her that you are with her. So that feeling of having somebody to call upon on need is itself a very good thing. Okay.
Yes, ma'am.
Thank you, ma'am. So as ma'am said, always you have to think about the emotional netting, because if they are able to ventilate their emotions, we can able to, they can share their emotions, and they will get a mental relief. And also the same time you have to think about the symptom management, especially this patient is suffering from constipation. Also, if the patient is having constipation, that time they will give a strain again, that will cause that leads to dyspnea again, will happen. So these are the things you have to keep it in mind all the time. You have to give a better symptom management, and also you have to think about the other aspects, especially psychosocial and spiritual aspects is important. You have to look into that also. Nurses, I know you will not get enough time to look all the three other aspects too. If your duty to find out this problem is there or not, then if you get time, you can listen. Otherwise, try to include a social officer, social worker, or a psychologist into the team, and then that people will explore their emotions. And also, always you have to think about the non-pharmacological management, especially music therapy and all. So, and if non-pharmacological management fails, you have to give a pharmacological management, like bronchodilators, or corticosteroids, or opioids, anxiolytis, whatever it is. So these are the group of medications which help to relieving that breathlessness. So you have to keep it in mind all the times. Okay. I think we can wind here. Time up. Thank you, ma'am, for the wonderful presentation. Thank you, Sister Manjula, for the presentation.
Thank you, ma'am.
For the interaction. So thank you once again, ma'am, for the
Thank
wonderful
you,
interactive
Sister
session.
Shiva. Thank you all.
Thank you, ma'am. Thank you, Shivama, for the presentation. Thank you, Manjula sister, for presenting the presentation. Thank you all for participating actively. Thank you, Dr. Greeshma, for presenting that wonderful presentation. Thank you, everyone, and see you in the next session. Bye.